Tēnā koutou, tēnā koutou, tēnā koutou katoa, malo e lau maari hou eik, le tonga dobe, nin sabula vinaka talo palawa, and warm Pacifica greetings to one and all. My name is Sione Tuitahi. I'm the Executive Director of the Health Promotion Forum of New Zealand. And it's my privilege and pleasure to welcome you to this Pacific webishop. We offer 3 categories of workshops, Maori, Pacific, and mainstream. And our next 2 workshops, our Maori workshop will be on the 5th of May, and our mainstream workshop will be on the 19th of May as well. But again, a warm welcome to each and every one of you. We are in the business of health and well-being. And as most of you know, the spiritual dimension of well-being is central to Pacific Health Promotion. And on that note, I would like to open our webishop today with a karakia, with a alotu. So let us pray for the well-being of our body, mind, and spirit. Thy name is my healing, O my God, and remembrance of thee is my remedy. Nearness to thee is my hope, and love for thee is my companion. Thy mercy to me is my healing and my succor, in both this world and the world to come. Thou verily art the all-bountiful, the all-knowing, the all-wise. Kia ora, malo bito, thank you. Again, a very warm welcome on behalf of the Health Promotion Forum of New Zealand. We have 2 wonderful speakers here today. You can see the topic of today's conversation on your screen. And without further ado, I'd like to introduce Dr. Viliami Puloka, who, by the way, is in Tonga at the moment, and Dr. Viliami Tutone, who is also will be talking from his office at the Middlemore Hospital at County's Manukau District Health Board here in Auckland. My team at the Health Promotion Forum, we are still working from home. There is Emma Frost, our IT person for today, and Lavinia Ngatoko, working from home as well, will facilitate, convey your questions to Dr. Puloka and Dr. Tutone. But without further ado, I'd like to hand over to Dr. Viliami Puloka to lead and facilitate and outline the rest of our webshop for today. Thank you. Over to you, Viliami.
Thank you very much, Sione, and greetings, Malolele here from Tonga, the island kingdom of Tonga, the friendly islands, of course. And we have a very beautiful weather out here, and we do extend to you a very warm welcome to all of you who are listening and from the different parts of New Zealand, and of course, quite internationally since I'm here in Tonga. Today's topic, of course, we decided to focus on diabetes. And of course, diabetes, I put it, and we thinking of diabetes as a societal malady with personal responsibility. And this is really just to note the significance impact that diabetes on Pacific community, of Maori, of course, and everybody globally. Diabetes has become such something that it really affects a lot of people. And most of the time we've been thinking about diabetes as a disease. Of course, it's a disease, but it's really have caused a lot of people to be discomfort, and to the extent, the next slide, to the extent that they think diabetes is almost like it's inevitable and everybody will have it And once you have it, there seems to be no hope. I want to start off by stating that diabetes is preventable and diabetes is reversible. Even if we have diabetes, it can be reversed. Diabetes is just like any other disease, and it's treatable, and it's not a life sentence. I have a lot of members in my family who have got diabetes. As a matter of fact, the reason why I'm here in Tonga, because my older brother has got diabetes. And some people, once they got diabetes, they think that they just wait for the next stage of diabetes. They waited for when they're going to have an amputation. They waited for the time when they will require to go on dialysis. And they just think that once you get diabetes, it's almost like a life sentence. There's no hope. But I want us today to reconsider our thinking, and from the evidence, and I'm sure Dr. Tutone will speak to that later on, the fact that is that we can do something about it. Diabetes is preventable. Diabetes is reversible. It's only a disease, and you can live well even with diabetes, and it's treatable, and it's not a life sentence. Yes, it runs in the family. All of us on the Pacific, we have a genetic predisposition to having diabetes, but that doesn't mean that everyone who have genetic predisposition to diabetes will have diabetes. It's not inevitable. It also depends a lot on our lifestyle. And diabetes, as I said earlier, every one of us knows somebody, if we ourselves have not got the experience of having diabetes. So diabetes really represents the whole issue about non-communicable diseases. And I think today, I would like us to remember that. And I think personally, and I believe that if we are able to get a good handle on diabetes, we will be able to face and handle and manage non-communicable diseases in general. So here are some learning outcomes of some of the things that today's talk we hope that will come into have some idea. I think it would be good if Tutone will show us what the magnitude and the impact of diabetes. And diabetes and obesity, of course. Now we talk about not just diabetes and obesity. There's a new terminology now. It's called, we refer to diabesity. It's such a deadly combination when you have diabetes or obesity and contributing to becoming diabetic. And I think today we also need to be mindful and to understand that yes, the individual has got the disease, but actually it is the society, it's the whole community. They contributed in one way or another. The social, economic, and the political determinants of health. Those are the things that influence a lot of the well-being of the people, especially our Pacific people. So we need to be thinking not just the individual who has got the diabetes, but what are the factors, what are the drivers in the society, in the community, in the church, and in our families that support or help people to become more diabetic or unable to control and put a good handle of their diabetes. And that's, of course, this is very, very important that we, even though it's still very important that every one of us individually, we have a responsibility to look after ourselves. And by looking after ourselves is in turn contributing to the welfare of the whole community. We are also looking after the society and the community. Likewise, the community to have a responsibility to help and support, provide an environment whereby the individual can become healthy. And then of course, our culture, our faith, our everyday living is very, very important. And we have some health promotion approaches that we hope that will help us in our, when we navigate our way and support those who have got diabetes. Next one. And this here, the key issues or things that we'll be talking about, and I'm sure Dr. Tutone will be enlightening us with that. Now we have a terminology referring to diabetes and obesity. We refer to as diabesity, and that's really a deadly combination. And we also have another term is referred to as obesogenic environment, meaning what are the things in our environment that support people to gain weight so much and therefore lead to diabetes. So those are the things that are important, the environmental factors, whether it's a policy, whether it's the built environment, whether it's a lifestyle, but those are things that we refer to now as obesogenic environment. There's always conflict on wealth and health. And I think this is another issue that we can talk to later on, but every time we care so much about trying to make a living, and then we sacrifice our health, lives and livelihood. And we all know that. I think COVID-19 has highlighted that even though that we need to make money, we need to create wealth, but in many cases, in doing so, we are sacrificing health, and it ought not to be. It ought to be a balance in wealth and health. And of course, a lot of things that's happening in society and in our personal choices, in the lifestyle challenges, those are the things that we need to pay attention to when we are addressing diabetes. And I think the last slide here is just some of the things that we can discuss later on. What are the health promotion approaches that we as people, whether you are a health promotion or community worker or working in the health system, that we can do? Of course, the essence of health promotion is to empower, to enable people, and mostly around the policy area. We need to pay attention to that. And of course, the other big role of us is to advocate, be the voice, and be the conduit through which support get to the people who need the support. And it has got to be the whole of government and the whole society approach. And we need to move away from just prevention to promotion. We need to move from where we are and just protecting ourselves not to get sick. But while we are well, we need to progress and we promote whatever the lifestyle or whatever thing, whether it's diet, whether it's physical activity, whether it's stop smoking or stop alcohol, those things need to be in the promotion, not just preventing from happening, but we progress from wherever we are today as we move into the future. And I think that's the last slide that I want to talk to. And I think unless there is somebody who have a burning question at this time, but I think Sione and Lavinia will speak to that. But I think at this time, I may invite our guest speaker, Dr. Tutone, who is a nephrologist. He happens to be another Viliami, something to do with Viliami, I think such a good name, and also a Tongan. And we welcome Viliami. Viliami, we have been working with him, and he has done a great job, not just being in the clinicals in the hospital, but he is now a great believer in health promotion. And we welcome you, Viliami Tutone, Dr. Tutone. Welcome again to the Health Promotion Forum series of webinar. And so I'll turn it over and hand it over to you. Malo apito.
Malo apito, Viliami, Sione, and welcome everybody. I hope you can hear me well from Middlemore, from the ground zero.
We can hear you well, Viliami.
Okay. So I'll start with probably what we should learn at the end of this talk. unusual for me to sit down and talk. I rather walk around and talk and looking at the big screen, but I'll try my best. These are the take-home messages that probably you should become familiar as we go along the presentations. And I think thinking of diabetes as just a disease in itself, I think we need to change that. We need to change our mindset in our attitude towards epidemic at diabetes. And I don't see very much difference between COVID-19 and diabetes, in a sense that the prevalence is very high and it's spreading very rapidly, and it's a worldwide problem, but particularly hit hard the South Pacific, us, with this problem. And when we refer to something as being epidemic, then it demands a different approach, not just clinical treatment as we made, but more veered towards health promotion and good primary care. And I still firmly believe that's where we should go. And after experiencing many years in Reno, not both in Middlemore, but also in UK, in Scotland, I've come to a conclusion that if we cannot get on with health promotion and good primary health care and try to tackle this problem, one could really think that we are in a process of annihilation, and I think the statistic will speak for itself as we go along. But it's not all doom and gloom. There is hope, as Viliami have stated before, and the current studies have demonstrated this, and I've seen it with my own eyes in clinic here in Middlemore, the effect of losing weight in terms of diabetes and other cardiovascular problems. Just briefly on the WHO classification of diabetes, there are many types, but I think we should focus on type 2 because it's the one that most commonly affected us, even though others also occur type 1. But type 2 is related to insulin resistance and closely mirror in parallel with obesity, and that's why we term it as that it's diabesity rather than diabetes, is because of the high prevalence of obesity in people with diabetes, and it's insulin resistance because of problem with beta cell dysfunction and sometimes association with metabolic syndrome. And it causes a complete destruction of every vessels in the body as the disease goes along. So it's a vascular disease, and every organ system in the body has vessels, and they are affected to various degrees. Young people are, as we know now, and we notice it, is very aggressive, the disease, both microvascular and macrovascular disease. And one could refer to it as a malignant vascular disease. There are risk factors associated with it, as Viliami alluded to. We've got genetic factors. We have got lifestyle factors, our dietary patterns. There are some environmental exposure. And I think I really need to bring up the point here that the earth is so small now that we can't think of healthy people if the planet is not healthy. So there is more to this than just focusing on diabetes. We have to look at the environment as a whole. There are medicine that we use. A lot of us are using steroids here in Middlemore for various immunological disease and transplantations. And there are some others as well, other risk factors. But if we look globally and look at the problem with type 2 diabetes, up to 2015, 2020, and the forecasts, it is likely to keep going if we don't have any good health promotion in primary care or change the tech that we are doing at the moment. Because as the trend shows locally here in New Zealand and worldwide, whatever initiatives that we put forward to counter this is probably not working. And you can see here in the global trend is increasing. But to make a mockery of this, if you look at Fiji and look at Mauritius, American Samoa, we are lumped in here. We are way up the scale up here in 100,000. This is 20. If you look at here, this East, Western Europe is about 9, 100,000. We are running at about 20, even more for us in Samoa and Tonga. We are in that figures. We are different subgroup in here of being over the scale. Now this from the same journal here, which shows the incidence and prevalence. I think the interest for me, if you look at this side here, the comparing of the incidents in 1990 and 2017, what worries me is not just if with each adjusted for every age group, it's not just the increase, but it seems to me the curve is shift to the left. What it really means is that people are getting diabetes at a younger age. And as I told you before, when you get younger, it seems to be more aggressive the way it affects the vessels, the vascular system. Have we observed it? Of course, we've seen it in dialysis. This is not just a suspicion, it is a reality, and I'll show it later. It is also very hard to know the actual prevalence of diabetes. And this is a study in the Auckland regions, and it's very hard to get data from primary care. But we do a sneaky way of doing it is get all people with the hospital number in metropolitan Auckland, use it as denominator, and look at all service users and try to calculate the prevalence of diabetes. And now this is 2013, the prevalence of diabetes in Greater Auckland, stratified in terms of ethnicities and age. And you can see from the red line, the Pacific is leading the way, followed by the Fijian Indian, and then followed by Maori. What concerned me is that this age group here is, you can see the Pacific, you can see it actually starts separating quite early, 25, 29, 30, 34. So this is 2013, but what we have noticed now in those that we've started dialysis, younger people, these are the people that is starting here. So it's probably worse now compared to those 2013. The same data, when we look at Greater Auckland and look at the number of people with diabetes, and it's poorly controlled, If you look at the last column here, look at the Pacific in Greater Auckland, 6,673. Look at the European, which dominate the population. There's only 4,435. So this data really shows not only that we got diabetes, the prevalence is high and the incidence is high. We are also those that are not being well cared for or treated or compliant. Diabetes follows very closely with the socioeconomic status. And here the graph shows the most deprived 10. And you can see that the prevalence of diabetes is higher when those with lower socioeconomic compared to those who are well off. And this graph here really shows it. If you look at the total population of New Zealand here, the New Zealand deprivation score, and you can see for Maori and Pacific, a great many of those are over, who are actually in a lower socioeconomic status. And if you look at the age group stratification, you can see most of those in age 0 to 14, 15 to 64. These are our people. These are our young people that are living on below the poverty line. The complication of diabetes is phenomenal, as I've said before. It affects every vascular system. And if we look at the organs here, everybody who has been working clinically, and particularly in diabetes, will notice all of this. This is not just have shown in here. There are other problems as well. And I think every single ward in hospital, if you walk in there, but in Middlemore, the problem is diabetes, whether that's surgical or whether that's medical or whether that's option gynae. I'm going to go through run some of the statistics that we have here in Middlemore, and really is a report from Ground Zero. Our dialysis population, by the end of this year, I think will hit 700. So far, we're about 670. So it's a huge program that we undertake here in Middlemore Hospital, and it's the biggest in terms of number in Auckland and Australia. Now, if we look at people starting dialysis in 2017 and compare ethnicity, New Zealand, European, Asian, Maori, and Pacific, we have diabetes at a younger age. The Europeans and Asian have at an older age. So if we just could take the crude data from there and compare, it doesn't give us the full picture because we don't compare apple and apple. because we have diabetes at a younger age and a lot of our population at a younger age. So the denominator is big. So it will just shows that the incidence rate is not that much. Whereas European and other population, they've got diabetes at older age and there are not very many, so the denominator is not that much. So to give us the true picture, we adjust it for age. So we say everybody's the same age. How many people starting dialysis per year? So for one, just look at the picture on your right. For one European starting dialysis now, there are 2 Asians starting dialysis now. There are 6 Maoris starting dialysis now, and there are 12 Pacific people starting dialysis now. So when you put it this way, we can see the magnitude of the problem that we're facing. Now, this graph here is showing this group here, the 25 to 44. Up to now, this group is starting to take off. And if you look at this group here, these are the Pacific and Maori. And having diabetes at a younger age is the problem. So with all these people that end-stage kidney failure that we have here in Middlemore, this is the data from Middlemore. What is the cause of it? And you can clearly see in this curve in here that diabetes is driving it. If you look at all the causes of end-stage kidney disease, it is diabetes. Now, if you look at the graph on the right side, for Pacifica, more than 72% is the driver for people on dialysis is diabetes, diabetic nephropathy, 68 for Maori, and 36 for Asian and European respectively. I'll just give you two patients, P and L, Mrs. P and Mrs. L. Mrs. P have diabetes at the age of 21, type 2 diabetes. L is 32, BMI of 60, BMI of 55, 3 young children, 4, age is starting dialysis 51, 55, working, not working, unfortunately passed away. This is 58. So you can see in this picture, in this table here, we're dying younger. We are losing the breadwinner of the family, and there's 3 orphans here. So with this, that we're seeing more often in Middlemore Hospital, and I'm sure every other dialysis unit, with younger people, Pacific people here, we are basically in the process of taking out or annihilation, as I've said before. And it's becoming more and more common occurrence in Middlemore Hospital. It is not just diabetes and dialysis we're looking at as diabetes driving dialysis. It drives other problems. We are leader in ischemic heart disease here in New Zealand, the stroke, COPD because we smoke a lot, asthma, all cancers. So those with vascular disease is the problem because driven by diabetes, we are on top. We are the top. Now, a brief touch on obesity. We are becoming more and more known of other problems that we haven't been defined before about diabetes, and very much so for us in Reno. We have now got a different diagnostic category of obesity-related nephropathy. The usual way the kidney is hit is through diabetes rather than obesity. But now we know this is different. There is a separate category here with obesity directly affecting the kidneys, and not through diabetes or hypertension. It also affects the lung and the heart because of obesity causing obstructive sleep apnea. They cause a lot of lung problems, which in effect increase the pulmonary pressure and destroy the right heart. When the right heart is destroyed, it limits the cardiac output. And we have seen this in the age 20s, between 20 and 30, because of the heart not working, the kidney fails. And we can't dialyze these young people here because there's no blood pressure. There is no cardiac pump to actually get the blood into the dialysis machine. So these people die very young. Our CMO in here in Counties Manukau has really now pushing this as the problem and try to actually set up initiative for the Pacific people and overall for Counties Manukau area. And as you can see, 36,000 people with PMI more than 40, and that's 9% of our population. That's quite appalling, really, when you look at it worldwide and compared to other parts of the country. There's a problem with obesity. How do we define that for us, for Pacific people? It is quite easy to calculate your BMI. Is that your weight in kilograms divided by your height in meters square? And the problem with this, it doesn't really differentiate someone who's muscular and someone who's more subcutaneous. And it shows up in this picture here. Someone who have the same weight, you probably, like me, would rather prefer with the one with a bit more muscles and not with the fat. And it's actually also depend of where the fat distribution, whether it's in your abdomen or whether it's in your peripheries. So the relationship with cardiovascular outcome is that the abdominal visual fat is the one that really pushes your cardiovascular endpoint and mortality is high. So we have to look at other measurement. If your waist for men is more than 1 or 2 centimeters and women more than 88 centimeters, I think you will also think, well, I'm in trouble, as well as the waist-hip ratio. But I think the problem is huge. We can see that will probably, whatever measurement that we do, we are generally big and we need to actually lose some weight. And it's none so than demonstrated here in 2015 about our obesity prevalence. Look at American Samoa, Tokelau, and Tonga. We are at a different level compared to the European countries, in that our obesity and diabetes are very high. One follows the other. So we do talk about bird flu, we talk about COVID-19, we do talk about global warming, but I think we should not let out of our sight our obesity, because that's the one that really hitting us very, very hard, and it's going to be a hard battle and a hard battle to go through. The question is that for us, is there any hope? Hope in this sense means we'll be able to reverse or able to push back for those who are nearly or pre-diabetes, or even people with diabetes. Yes, we can treat diabetes and prolong their life to some degree, but not very good at it. The hope is actually trying to push them back in the other direction. The red arrow here shows the death rate or mortality rate. The slide here shows the evolution of the treatment or medicine that we use for diabetes, and they are non-pharmacological. The problem with all this medicine, if you look at outcome, they barely made a dent on our mortality rate or comorbidities as we picked as we go along. Your stroke, your heart disease, and all of those, your amputation, it doesn't change that much. The hope is for us, so those who had excessive weight to lose weight, and for health promotion in primary care to prevent weight gain in our community. That's the hope. That's where it lies. And if we look at evidence, we can retrospectively look at our histories. Captain Cook, in his account in 1777, how healthy we are, except for the chiefs, where obviously they are more larger than us, than the working people, which shows the combination of diet and working. Now, it becomes more fashionable now, bariatric surgery, and there's a lot, and probably a lot will be done in Middlemore and worldwide, and it becoming a specialty on its own in terms of combating obesity by bariatric surgery. And this is one of the journals that they even formulate a tree diagram on looking and stratifying people with risks and taking those with a higher risk and going into surgery. Is that work? It does work in all studies. And this, even though these are old studies, newer one shows though, it shows that excessive reduction in losing weight, 55% of excess weight or 38.5%, you lose diabetes, 78, nearly 80%, 8 out of 10 lose their diabetes status. It also helped with the metabolic syndrome as a whole. So really, if you look at it in terms of treatment of those that are already diabetes, it reverses it. It also in prevention, people with obesity, and if you lose weight, whatever mechanisms it is, whether it's surgery or whether it's diet and exercises, you also prevent getting diabetes. So as a diagram that I've shown before, we can move back to the left for those that have diabetes, or especially those that are just starting to have diabetes, to actually shift you to the left to a pre-diabetic stage. And also we can prevent. So again, the take-home messages, and I think I have convinced you that it is an epidemic, and the demand for the institution of a very good health promotion framework, and also a good primary health care. There's a whole lot of framework around for us here in the Pacific, but it hasn't been put into tests in a community. Now, this is one that we use with the fellowship, the church members, the church leaders here in Auckland, here in New Zealand. And this is the Whanuaora, this one, the framework, where we look at 6 domains, where we look at the well-being of the Tongans or any other group. We have to address each of these domains and try to push them forward. They are interrelated and they also depend on each other. Now, I want to just give you some ideas, a little bit more provocative really towards the end for discussions. We need some transformative changes. And if we look at us, there is an individual, there's a community, there's the institutions, the government, other institutions as well. And all these 3 protagonists should work together, should be flow freely between those 3 in terms of working together to achieve an outcome. In this case here, for us to prevent diabetes. But really, when you look at each individual in a community, in the institution, we should move forward. That's the transformative changes. And I just can't help thinking, how are we going to move forward if we don't have justice, equity, equality, love, generosity, selflessness, our vision to be human embraced, to have unity. And I think these are the qualities that so lack of in a community and around, that pushes us to actually make these transformative changes. And if you look at the left side, the destructive pathway here, there's so much of it in the community: injustices, inequity, culture of consumption, where the accumulation of material wealth is the source of happiness, selfish, inward focus, self-ambition, egocentric, and whatever it is. And I think if we look at the fabric, it's not just health, but if we look at the Whanuaora here, the fabric of the society is disintegrating because we don't have the quality to actually move us forward. It has been a long time in medicine and along around the world, and the depressing look of the renal ward of what we found, what I found, really look at our people dying young. I just can't help to think about the quality that each individual, those in the community and those in the institution should have to actually move us or provoke some transformative changes in whatever direction that we want to, the good endpoint. With that, I'd say thank you from Ground Zero. It doesn't look this bad. I mean, the color is not there, but this is Middlemore. Thank you.
Thank you very much, Viliami, Dr. Tutone. you really hit the nail on the head. And I think it is such a rich message that you have shared with us. There are a few points that I wanted to highlight here and then allow others to make their comments or questions. But I think it is so important that you're emphasizing that diabetes is no longer just a disease, and therefore the solution doesn't lie in the medical alone. It is something to do with the society as a whole, but also it's more in the realm of the spirituality and our faith and our hope. That's really what will get us out of this year. It's not just the tablets and the insulin and all that, but I think we have to move out of that one. The other thing is the fact that you stress very strongly that it's not just a metabolic problem, it's a vascular disease. And as such, it affects every single organ because every single organ has to have a vessel, a blood vessel. So this is a big deal, especially with its relation to the younger people. I think this is a disaster. Thinking that you are younger, usually if you're younger, it means that you will fare well and better with disease, but with diabetes, it's not. If you have diabetes younger, it's longer that you have to deal with it, and the consequences of that is not good at all. And the last point, I think, is talk about the relationship of poverty, and you refer to quite rightly. We have to have justice. We have to have equity. And it seems that clearly from your statistics, there's those regions where people are not as get access to resources. They seem to suffer more with diabetes. We used to, when we were in medical school half a century ago, we were taught that diabetes and NCD in general is a disease of the affluent. It's only of the rich people. But now, it seems to be the disease of the poor. And I think for us Pacific people, it's not poverty in terms of just money and resources, fiscal resources, but really a poverty in mentality, poverty in hope, poverty in faith, poverty in our caring. The very thing that we're so proud of as being Pacific, caring and looking after each other. I think we need to consider and to go back to those values to be able to lift us out of where we are at the moment. And I think, but I just want to thank you very much, Viliami. And lastly, actually, even for me, I did not realize that a lot of things now it doesn't have to go through obesity, diabetes, and then heart disease in that sequence. Now it's just bypassing, just direct from the obesity to all the consequences that we usually think that is because obesity causes diabetes and then diabetes lead to those others. So thank you very much, Viliami, and now I'll leave it probably to Sione to mentor and to direct the rest of our questioning and the rest of our session. Thank you very much.
Thank you, Dr. Tutone, and thank you, Dr. Puloka, for that wealth of information with regards to this pandemic, as Dr. Tutone, puts it, of diabetes. Apologies, technology is just yeah, apologies again for that technical hiccup, but I'm back online. And I was going to say thank you to Dr. Tutone and Dr. Puloka for that wonderful presentation, rich in information, but also solutions that we can look to. Your presentation, Dr. Tutone, has been quite wide-ranging but especially focusing on the status of Pacific peoples here in Auckland, but he also brought region-wide data to illustrate how prevalent and how serious this health challenge to our peoples. I noticed also that there are some questions, and we will start with that. So I'd like to call on Lavinia, our communications consultant, to please ask those questions, and we'll start with that. And then the floor will be open for discussions. And for those who would like to turn on their camera, you can actually do so that we can have a more, although still virtual, face-to-face conversation with our two speakers for today. I hope, Viliami, you can still hear me all right there in Tonga.
You're on mute.
We hear you loud and clear.
Wonderful. So over to you, Lavinia.
Thank you, Sione. Thank you for that great presentation, Dr. Tutone. I have a question here from Sasha, who asks, also thanks you for the insightful presentation, and asks, can you please explain how interventions can reverse insulin resistance? Do cells become responsive to insulin?
Yeah, that's the thinking now. The actual mechanisms of how is that reversed is not fully understood. But when you become fitter and lose your weight, your muscles and other organs able to take the glucose out of your blood system much more easier with less insulin. So hence the less insulin resistance. But it does, we've shown that.
Thank you for that. Mariana Tapere asks, how can non-Pacifica health promoters get in with the Pacific community?
That's a very good question to both doctors, especially Dr. Puloka in Tonga. If you start,
Come again, Lavinia. Oh, sorry, Lavinia. Come again.
How can non-Pacifica health promoters get in with the Pacific community?
Many ways. You can either marry a Pacific person or have a boyfriend or girlfriend. No, really. More seriously, I think this is a very important issue. And we do have a lot of talk about cultural competency and cultural safety. And I think, of course, we cannot really be in the shoes of others, but I think the main thing is to just have your respect and be prepared to be kind and respect other people's opinion. But I think this is more in a level of your cultural competency but basically we are all human beings and our basic needs are pretty much the same. Our cultural differences, some variant to it, but basically if we just respect each other, it doesn't, regardless what culture that we will be able to get along. Yeah.
Thanks, Viliami. There are no more questions, Sione, and over to you. Everybody feel free to put your questions in chat if you have any.
Thank you, Lavinia. Let me check with Dr. Tutone, see if he has got any views on how our non-Pacific colleagues can work with Pacific colleagues on addressing this issue. And I think this is a wonderful question for a more open discussions. Other participants, I noticed there are some there with some experience they would like to share. But over to you first, Dr. Tutone.
One of the issues that raised in this question is workforce. And I think this is issues has been raised at different level, is that the workforce involving us to actually spearhead our community. But I think that's something we can't wait for, something that we need to move. And I think we should open up for whatever or whoever it is that can help us. Really, I think I've talked about unity as a principle that moves us forward. And I think we should start thinking about unity and thinking about oneness. in this case in here. So we can define them in non-Pacific and we define as Pacific. But if we move closer, that we walk across and thinking in unity and in diversity, but unity and oneness, I think we'll be fine. And I think everybody will felt the intention, the pure intention of someone to do a work, even though it work across ethnicity, it's still, that tune sounds right. But I think even though we have workforce to develop for us because of the issue of cultural sensitivity, we should start thinking about unity as well as in oneness.
Can I ask a question? Talking about obesity, especially in places like South Auckland, what about the proliferation of junk food outlets and the advertising that goes with it? That's a big problem as well. Yeah.
The studies have now shown that in Auckland, if you place KFC and McDonald's, the highest density of those in South Auckland, yeah, it is proven. And I think it's a regulatory group that has to look in that. But we can't just blame them in the regulatory group. It has to come down to the individual as well. And I've said before, the protagonist for us to move forward is individual, community, and institution. And all must work together to try to actually reduce that proliferation, because I mean, some of these are quite manageable for large families. That's their own money they can get. They can get some of this junk food. That's what they get. They will get. So we come back to economy and socioeconomic status again. So unless we address that problem, it's very hard for this to disappear.
Thank you.
If I may add on to that last question that you asked, Lavinia, on the prevalence, the proliferation of food outlets, especially food outlets that are not very healthy in certain parts of, let's say, Auckland here, as Dr. Tutone, pointed out. There are more of such outlets in the low socioeconomic, suburbs in Auckland. And so a health promotion approach to addressing such challenges is actually to make sure that the environment is very supportive, meaning that the environment has got less of those health hazards, whether it's alcohol, whether it's tobacco, or whether it's unhealthy food. And if I may link that also, that health promotion approach to address the earlier question of the workforce. How can non-Pacific health promoters and other health workers can work together with Pacific health workers to address this issue of diabetes, and for that matter, any other health challenges that we face. We take an upstream approach down to a low stream approach. And upstream, as Dr. Tutone and Dr. Puloka referred to earlier, that we look at the policy, what decisions are made in terms of the configuration of our workforce. There is a principle that the workforce should reflect the profile of the community that it serves. And that means that if, for example, if Pacific peoples make up 8% of the total population of New Zealand, it therefore means simply that 8% of the health workforce should be Pacific. In terms of Maori, it's close to 20%, the total population of the country, and therefore the size of the Maori workforce should reflect that percentage. And we are fortunate in New Zealand to a great degree, actually, that we have in the health sector, initiatives based on policies that are trying to address that inequity within the workforce. There's more resources being invested into increasing the number of Pacific peoples in the public health workforce, in the clinical health, and that goes across the board to the education sector, justice system, education sector, and other sectors, especially those that there are challenges for Pacific and Maori and other groups as well. So that's an upstream approach, looking at policies, looking at resources, how they are allocated. But coming down to a more lower level, where the reality, where the challenges are really at, the community approach is equally important to make sure that the community itself can actually be equipped with the relevant skills to address the challenges that they face, including diabetes. And I think Dr. Tutone, what he showed earlier about the model for Nuaola and other such models, the Samoan community, there is Whanofare, models that are based on the realities of the Pacific communities, that are based on their values, principles that Dr. Tutone spoke about, values of reciprocity, of sharing resources, of helping one another, of kindness and love, as our Prime Minister has been saying all along in our approach to addressing COVID-19, but also some skills that are based on the experience of the Pacific communities. So there is an equally important role for the community to play in addressing these issues. And one of the ways is to look into their own principles and skill set to come forward and help. At the end of the day, this is a societal effort rather than just leaning and waiting on the doctors to make the decisions and to offer the solutions. We need to all work together. As Dr. Tutone said earlier, we, the individual, the community, and the institutions, whether it's government or private sector or community sectors, we need to all work together, because diabetes, like many of the other health challenges that we face from a Pacific perspective, it's not just a health issue, it's not just a health challenge, it's actually broader, and then that it affects our economy, our education, the environment, the lives of families, income, and all of that. So we need to all work together. There's a kind of a long-winded answer, but I'm trying to respond to both those issues that you have been raised: how to address the workforce, the challenge of having the right number of people, as well as the right set of skills, but also how to deal with health hazards like food outlets that are not so healthy, tobacco, alcohol, and so on and so forth. Back to you, Lavinia, if there are other questions.
No more questions, surprisingly enough. So.
Yeah, if I may just add on to what is being said, and just going back to the theme that we put up for the discussion today, declaring that diabetes is a societal malady with personal responsibility. I think it has been demonstrated very well from Dr. Tutone's presentation. For a community, the Pacific, to have such a high percentage of people being sick, not just sick, but killed by this one disease, it cannot be just the individual responsibility, even though the individual has a big responsibility. But I think we better wake up as a community, as a Pacific community, and think again, what has gone wrong? Or what can we do as a community to contribute to the welfare and well-being of our people, the Pacific people? We cannot allow this to continue. And some people say that it shows the inequality, because if this happened to another population, probably the government and everybody will be jumping up and down to do something about it. But happening in our community, and I think the solution really is within our hands, if it's with us. Yes, the government will do their contribute, and they have a very power and authority to do that. But I think we must begin with us. We must begin with our families. We must begin with our churches. We must begin with our own whānau, and we must begin to do something, and we must do it now. We cannot continue to reflect on these terrible statistics next year and the following year. I think as part of this rich discussion that we have here, and thank you again to Dr. Tutone for bringing home this very clear message that I think we ought to begin and must do something. Lastly, I just say that they all talk about the what Sione was referring to as the population to reflect it. I think sometimes we worry so much to be politically correct that we have to be of a particular culture in order to speak to the same culture and something like that. I think the beauty of being in New Zealand and in other countries as well is the diversity and unity. The fact that we come from different cultures and different perspectives really enriches, provides an opportunity for us to share in spite of our differences. And I think this is something that we need to, as Tutone was alluded to, that we must come together, we must be one, but also respecting each other and be aware of the richness that's being provided by being us having different culture and diverse in our thinking and the things that we are doing. So I just want to add that on and thank you again to Tony and for everyone. And I hope maybe I see Tavita Finau keep on unmute and mute. Did you want something to say? You just want to say something?
It's all right with me.
I'm happy to also add on to the fabulous work that you're all doing. Whamalo lahi atu Dr. Tutone and Sione Tuitahi. And thank you for the honor to be part of this conversation. As I reflect, I wasn't there right from the beginning, but as I reflected, on the stats you've given us and the stats that we've seen time and time again about our Pacific community, it is about doing things differently. I'm really happy to see that that we're looking at a holistic way of dealing with the situation. If I think about the families that we work with at Aotearoa, and usually health is definitely the last thing on their minds. The first thing is getting food on the table, getting the kids educated, making sure it's a stable home free of violence and it's safe. And I think about how poverty plays into this, because if, like what the conversations we've been having, if you're going to choose a cheaper meal that can feed the whole family, or a more expensive meal, but not everyone can eat, that's a real question. That's a real question that we have to ask ourselves. In the health space, I just recently had conversations with one of our education team, and they're talking about literacy and numeracy. They're reporting soon, and they said to me that the families that they work with, for example, during lockdown, it's not even our children are not even doing literacy and numeracy because they don't have enough laptops in the home, because there's because everything has gone to online for lockdown. You know, there's no space in crowded homes where 94% of our families that we work with live in 2 or 3 families living in their home. So there's not enough space for the kids to study, not enough equipment for the kids to use to be educated. And it's not a priority for the parents because the parents are still trying to put food on the table. So when I think about health, and I think about the community that we serve, it's not the first priority on the minds of our community. Our families want to feed their children. And if you had to ask a parent, you know, would you rather give your children healthy foods, not full of poison and processed food? Of course, they're going to choose healthy foods. But sometimes it's not a choice. In fact, for a lot of our community, it's not a choice. And your stats show it is not a choice for our community. So we can't just look to health for the solutions for the health of our community. It has to be holistic. Just with education, you know, you can't just sit and help someone with their homework. That's not good enough because those children will not have the ability and the tools to sit down and do their homework. So, I mean, this conversation, you know, we won't have all the solutions, but I think the best and the first thing is that we are working together, that the church is part of the conversation, that social services are part of the conversation, that ethnic specific services are part of the conversation, and that the different sectors know that they can't find solutions for their areas on their own. I was just recently talking with one of the government sectors and I said, you know, it's so hard for community people such as ourselves to voice what we are currently talking about to one sector at a time. The government has to be fully on board. And it's good to see with some of the ministers that are on board now who can see that there needs to be a bigger voice for us as Pacific in health, in education, and social services. So I look forward for the continued conversation, for us to find those solutions together. You know, we all play a part. Listening to the presentation today tells me how urgent it is for us that works in the community to get to a space where our families do start to consider health as a priority, which means there's so much work that we have to do for families to start to see that the foods that they buy, the change of lifestyle. You know, when I was listening to the presentation, there was one part, you know, we're talking about the choices that we make. And I think about our typical island family or Tongan family, where both the parents are working long hours, maybe physical jobs, definitely mentally and emotionally. And when they get home, there's not enough money in their account because they paid off all their bills. And now they have to look to the children to see, okay, how are we going to feed them? They're not thinking about the health of their children. You know, they're just thinking, okay, we need to put food on the table, go and get someone go down the road and get food that can fill us up, not healthy, but fill us up. And then let's get to the next day, or let's get to the next paycheck. And that's, I have to say, that's pretty much a lot of the families that we work with. And so when we come into these meetings with yourself, Sione, thank you so much for allowing me to be part of these meetings. It reminds us that, you know, there's so much work to do, and that we can't work in silos. That this is an effort that we all have to come together in. So thank you so much. Yeah.
Thank you, Kathleen, and for that very insightful sharing, you know, based, of course, on your really on the ground work, you know, reading very accurately the realities of our Pacific communities. And it's the side of the story that we in the health sector need to hear, especially health promoters. We try our best to train our workforce and reach out, but unless you reach us as well, it won't work. And so, the anecdotal information that you have shared actually very useful to us, and we should continue this dialogue. And perhaps to provide a brief background so that other participants aware of who you are and what you do. Kathleen is the Executive Director of Aotearoa Services. It's a faith-based service, Methodist Church in New Zealand, the Tongan community. And it's based in Auckland, but it has a nationwide network reaching out to other Tongan communities where they are members of the Methodist Church throughout the Motu here in New Zealand. And their service is not confined only to members of the denomination. It's open to other people of other denominations and faith. I have observed, the work of this wonderful team. And in fact, without your service, the story of the current COVID-19 will be a different story, a sadder story, for the Tongan community and other Pacific communities in Auckland. Thank you to that. And as you stated clearly, as the two medical colleagues shared, it's a societal challenge, not just for us in the health sector. And there are many factors contributing to that, social, economic, but also the pivotal role of faith-based services and communities is that you bring the spiritual dimension, the ethical and moral dimensions that Dr. Tutone point to. We need to work together in unity. We are fellow human beings, and our collective resources, we need to work out a better way of distributing that more equitably. COVID-19 has really showed that if we do not work together in kindness, as our PM has mentioned quite many times, if we do not love our neighbors and share, we will all die together, really. And, so again, thank you for that. You might want to, so this is the time of our webishop where participants can actually, share your views on the questions or any other issues related to this big, broad topic of diabetes that Dr. Tutone has, challenged us with to really think in transformational ways, not just piecemeal change. It doesn't work anymore. We have to think outside the basket, think outside the box. But thank you again, Kathleen. Lavinia, any other questions from other participants?
Oh, no more questions, Sione.
Well, if there are no more questions, I will give our two speakers, a final opportunity to each to any concluding thoughts, where to from here, what can we do, and how can we continue this conversation. To you, Dr. Viliami Tutone first, if you have any final thoughts.
In terms of continuation, I'll leave it to Dr. Puloka. I think my final comment is that if we embark on intervention to counter this, one has to know that it has to be a sustained intervention for a prolonged period of time before we can see the change in prevalence. And I think if we have an effective way of intervention of health promotion in primary care and having to address all the domains that I put down for Nuaola, we have to wait for 20 to 30 years before we see the turn on the corner. So it's not something that we can just go on it now and then it shows into fruition in about 5 years' time. It has to be a long time. And I think that's one of the problems when we look wider into the political in our system. is that we have elections in every 4 years. And then sometimes that continuation of that sustained effort, it becomes a problem in trying to actually get it through. Because some of the problem that we have to tackle is what that we see now, not what comes in the future. So it is, sometimes we can look at it as a limitation, but the problem is so bad that we need to rise up, as Kathleen said, start talking and start doing something about it. Not all will be saved, but at least we move forward. Thank you.
Thank you, Dr. Tutone. Dr. Puloka in Tonga.
Malo, and thank you very much, Dr. Tutone, once again, and to all of you. Catherine, always very exciting, the reality check that you are bringing into our conversation. I think there's always a lot that we can talk about, and obviously there's a lot that we can do. But I just like to challenge each of us here. Do you know your numbers? Have you, when was the last time that you check your weight and you check your status of diabetes? I think let's just be serious and begin with us. Let us be the change that we want to bring about. Let us be the transformation that we are talking about to be happening in the community, and start with us. And I also like to challenge all of us that all this very nice and factual message that we're giving out, let the message and the messenger be one and the same. Again, it has to begin with us. We do tell a lot of these to others. I remember when I working here in Tonga some years back as a health promotion, as a public health, and as a physician here. And every time we go and hold a workshop in the villages, and then at one time, one of the people in the villages look at us after all our talk, and they say, until and unless we see that your staff look like what you are preaching, it'd be very difficult for us to follow what you are telling us to do. So I'm very, very serious, and I think that we need to begin with us. Let's be the change. Let's be the transformation that we wish the rest of the Pacific community to have. Malo Abito, thank you very much.
Malo Abito, Dr. Puloka, and to respond quickly to your question from a personal level, that is myself. I know my numbers, but I won't let you know at this point. But also, I take seriously that, at the personal level, I'm actually standing up while we talk. I've been walking, as we, been proceeding with our webshop today. And again, thank you. And I did acknowledge our colleagues and friends and family from Tonga, but again, I'd like to thank you for participating. We thought that we take the opportunity of Dr. Puloka being in Tonga there, doing some work for us, and Otago University, where he also lectures, to connect and to have this wonderful conversation. Special acknowledgement to leaders of the Pacific community who like Kathleen and some of the church leaders who are here for being able to be here today, and our non-Pacific colleagues. We are all in this together. It's a collective effort. Our well-being is our total well-being. Your well-being is my well-being, and hence this effort to have this conversation. And thank you again for coming together today. As you know, for participants, we will share this video for your private view in 2 weeks, before we put it up on our Health Promotion Forum YouTube channel. I can see on the screen that Lavinia is asking if you want to be in the group photo of this webinar. You can switch on your camera, otherwise that is fine. We respect your privacy and your your decision. But finally, Dr. Tutone and Dr. Puloka, thank you very much for organizing this webinar. And thank you for sharing us with your wisdom. We will reflect and think about what you have shared with us and the challenges, not us just in the health sector, but also those who are leaders of our community. And to everyone who participated today, again, on behalf of the Health Promotion Forum, thank you for being here today. We started off with